A very good evening to all my teachers, seniors, colleagues, and friends. Today we have the second session of the Journal Club by IAP Thiruvananthapuram in this January, and we are blessed with Dr. Ramankutty sir with us. We have blessed with Ramankutty sir. We have Ramankutty sir, Hariprasad sir, IAP president with us, Padmanabhan sir, Dr. Zulphikar Ahmed sir, the PGs, and we think more people will join. Before starting the session, I would like to hand over the mic to Dr. Benno, Secretary, IAP Thiruvananthapuram. Out to Dr. Benno.
Thank you, Juganmi sir. And as sir said, we are actually continuing with our flagship program very meticulously. And I'm very thankful to Anju Kanmini sir, Ramankutty sir, and Padmanabhan sir for helping us continue with our journal club presentation. And so we have the presenters, both from Cosmopolitan presenter and the analysts, both from Cosmopolitan Hospital. So presenter is Dr. Arya SR and analyst is Dr. Bhavya Makwana. And mentor is none other than our IAP Trivandrum Treasurer, Dr. RoseMary Lawrence. And so before we go to the session, I would like to call upon our IAP Trivandrum President, Hariprasad sir, to give the keynote address. Over Hariprasad sir.
Okay, thank you, Benno. So, most dear and respected Zulfi sir, Ramankutty sir, Padmanabhan sir, and Anju, and all my friends. Because I think this is a very flagship program of IAP Trivandrum, and I'm happy that our journal club is going very strong. And I'm really grateful to Ramankutty sir, Padmanabhan sir, for taking this forward. And I sincerely thanks Zulfi sir also for joining for today's session. And thank you all. And over to, I wish this program all success, and I hand over the mic to Benno once again. Thank you all.
Thank you very much, sir. Now I would like to call upon our academic coordinator and an immediate past president of IAP Trivandrum, Dr. Rukmani K, to speak a few words. Over to Rukmani, madam.
Our respected Ramankutty sir, Padmanabhan sir, Zulfi sir, and all other colleagues and friends. It is nice to see that Journal Club is going on for the last 1 year, and it is going strong this year also. Even though the number of participants is less, but it is 1 hour quality time spent. So whoever is logging in, they will definitely benefit. And I think even though the number of participants in the Zoom program is less, the YouTube channel is reaching many, I think. So let us continue this good effort and gain from the expertise of our teachers. Thank you very much. All the best.
Thank you very much, madam. With permission of Anju sir, I would like to call upon Zulfi sir to speak a few words.
Yes,
Zulfikar sir.
Sure, sir.
Hello, thank you very much for reinducting me into the what you call as journal club. I think journal reading and trying partly successfully analyzing and reaching a conclusion has been very interesting. It's almost like arithmetic or mathematics when we did our school days. So it has that kind of algorithmic approach and reasoning. I think that makes it more very attractive. I mean, the case discussions, talks are all good, but I think Journal Club has a different point of view. I think that makes it more attractive. And the number, as Rukmini said, number may be less, but doesn't matter because if you have 20 people listening to it and discussing, and you will get at least 3 or 4 major insights into how an article is read, written, analyzed, and all those things. I think thank you very much for inviting me to speak on this particular area. Thank you.
Thank you very much, sir. Now I call upon Padmanabhan sir to kindly speak a few words.
Yeah, only 2 things. When the topic came up, first I thought, why this? because this is a highly specialized topic. But the fact of the matter is that the 1/3 of the epilepsy are resistant, and 2/3 may be, say, very easily controllable, and they become. And if you have seen a patient with these resistant epilepsy, which I have done, even though we don't manage directly now, probably we leave it out to the pediatric neurologist, but when they come with seizures, we see that the suffering of the family is terrible, especially when they fall down, have a head injury, and when they have to wear helmets so that all the time, so that therefore, if the seizures come from 20 per day to even 2 per day, it is a great relief for them. Therefore, when I read this article, I was wondering whether this will ever be available in India, and we can give some relief to these families more than the patients themselves. I look forward to the analysis of this article itself, because I don't know any patient who is on this medicine in cannabis medicine in India. I'm not sure. Okay.
Can I add to that, Dr. Anju, or should we go to the analysis now?
If it's short, I can keep it short and just because I think I'll just give an intro and go to this.
Okay.
Yeah, thank you so much, sir. Yeah, I'll hand over the mic to Anju Kanali, sir. Sir, we can.
Thank you very much. As I think Dr. Padmanabhan sir, RoseMary has very much to talk about this. Has got much to talk about this cannabis as well as this article. But I think I will just give 2 or 3 words before going to the journal proper. Now, today's journal is Epilepsia, which is a leading authoritative peer-reviewed medical journal focusing on innovative clinical and basic science research on all aspects of epilepsy and seizures. This monthly journal was established in 1909, and it is an official journal of the International League Against Epilepsy. The impact factor of the journal is 6.04. And as far as cannabis, as I was telling, we all know something about it. But I would like to share a few things about this cannabis, that there are 3 forms. It is cannabis sativa, cannabis indica, and cannabis ruderalis, and is available in 3 forms. The hashish, which is the resin, and the marijuana, which is dried leaves and flowers, and hemp, which is industrially cultivated. And as madam will be telling, there are 2 active cannabinoids, that is delta-9-tetrahydrocannabinol, THC, and cannabidiol. The THC is this one which produces the euphoric effects associated with cannabis use, while CBD, that is a cannabidiol, elicits broad antioxidant and anti-inflammatory neuroprotective effects. So that is the importance of this article. CBD is more effective than placebo in managing treatment-resistant epilepsy, according to systematic reviews and meta-analysis. And all the things like cannabinoid receptors and the ligand, anandamide, everything, the neurotransmitters, dopamine and norepinephrine, those will be dealt with later. And we should note that in children, sometimes it happens in accidental exposure, and when the accidental exposure occurs, it will be large amounts that can lead on to encephalopathy, hypotension, respiratory depression, and death also. Because recently also in Kerala, it was available as sweets like gummies and all. Many countries have legalized recreational use of cannabis as well as the medical use. Then the Section 2 of the Narcotic Drugs and Psychotropic Substances Act, NDPSA Act 1985, has declared it as illegal. NDPS prohibits the sale and production of cannabis resin and flowers. But the use of leaves and seeds of the cannabis plant in India is permitted, with the states having the power to regulate. The punishment can range anywhere from 6 months and 10,000 fine to 20 years and 1 to 2 lakhs. It has been shown as from 2000 BC, even in India, it has been shown that it has been used in medical conditions, and the preparations like Sativex, Nabilon, etc. has been already there. And in 2018, the United States FDA approved this Epidem, the drug that we are discussing and all. just got very important role in treating Lennox-Gastaut syndrome, Dravet syndrome, etc. And there are side effects like gastroenteritis, vomiting, etc. And in Indian steroid, as Madam will be telling, there is one cannabis research project for CSIR IIM in Jammu, and companies like Biofor and Reddy's have come forward with the legalization of this marijuana. So today, the article will be presented by two enthusiastic PGs, Dr. Arya SR, the Junior Resident Cosmopolitan Hospitals, and Dr. Bhavya M. Makwana, Junior Resident Cosmopolitan Hospitals. Arya will be presenting, and Dr. Bhavya will be analyzing. Over to Dr. Arya for presentation of the topic. Dr. Arya.
Yes, thank you.
Good evening, everyone. I'm going to present the journal on the topic of long-term efficacy and safety of cannabidiol in patients with treatment-resistant epilepsies, 4-year results from the Expanded Access Program. Introduction. The cannabidiol is phytocannabinoid derived from cannabis sativa plant that lacks the euphoric effects and abuse potential of delta-9 tetrahydrocannabinol. Highly purified pharmaceutical formulations of CBD has demonstrated effectiveness in diverse epilepsy syndromes, including focal and generalized seizures. Treatment with CBD reduced frequencies of seizures associated with Lennox-Gastaut syndrome, Dravet syndrome, and tuberous sclerosis complex with an acceptable safety profile in 5 randomized controlled trials. Long-term safety and efficacy of CBD were demonstrated in the open-label extension studies. Add-on CBD treatment was well tolerated and sustainably reduced seizures in patients with Lennox-Gastaut syndrome and Dravet syndrome for up to 3 years. The CBD Expanded Access Program was initiated in January 2014 to provide CBD to patients with treatment-resistant epilepsies and evaluate its safety and efficacy in patients with diverse epilepsies and seizures. Objective of this study is to assess the long-term.
Arya, I'll just mute the participants. Yeah, 1 second. Yeah. Arya, you can unmute. You can unmute yourself. Arya, unmute. Okay.
Objective of this study is to assess the long-term efficacy and safety of cannabidiol as an add-on treatment for patients with treatment-resistant epilepsies. Methods. This is an open-label trial observational study of 892 patients with treatment-resistant epilepsy who were receiving stable dose of seizure medications. Parents or caregivers kept diaries of all countable seizure types during the 4-week baseline period. After the baseline period, all patients received a pharmaceutical formulation of highly purified CBD. All patients who receive CBD visits every 2 to 4 weeks through 16 weeks and every 2 to 12 weeks thereafter. The intervention used in this study, the participants received a pharmaceutical formulation of highly purified CBD oil, Epidem. The dosage was increased gradually from 2 to 10 milligram per kg per day to maximum of 25 to 50 milligram per kg per day, depending on the site study. Eligibility, it is for those patients diagnosed with epilepsy, likely including a specific type like Lennox-Gastaut syndrome or Dravet syndrome, and documented history of treatment-resistant epilepsy. Ethical consideration, written informed consent will be obtained from parents of children and adult patients. Sample size, it was not calculated before the start of study, but was dependent on the number of patients enrolled at the study sites. 892 patients were evaluated and included in the safety analysis set. Of 892 patients, efficacy data were available for 840 patients, which were included in the efficacy analysis set. The statistical analysis of this study, it compares the median monthly seizure frequency before and after CBD treatment. The efficacy endpoints included percentage change from baselines in median monthly convulsive and total seizure frequency. The responder rate analysis categorizes the participants based on their response to CBD treatment. The responders might be defined as those with more than or equal to 50%, more than or equal to 75%, or 100% reduction in seizure frequencies. The data was analyzed descriptively for the efficacy analysis set and using the last observation carried forward LOCF method to account for the missing data. Variables: age. The confounding variables are baseline seizure frequency, type of epilepsy, concomitant medications, and adverse events. Outcomes. The primary outcome was change in median monthly convulsive and total seizure frequencies from baseline. Secondary outcome, the responder rate more than or equal to 50%, more than or equal to 75%, or 100% reduction in seizure frequency, seizure severity, quality of life and safety or tolerability of CBD treatment. Results. The results of the study of 892 patients in the safety analysis set, 322, that is 36% withdrew due to the lack of efficacy, 19%, and adverse events, 7%, were the most commonly reported primary reason for withdrawal. The median age was 11.8 years, ranged from 0 to 74.5 years, and the patients were taking a median of 3 anti-seizure medications at the baseline. The common anti-seizure medications were clobazam 47%, levetiracetam 34%, valproate 28%, and the median top CBD dose was 25 mg per kg per day. The median exposure duration was 694 days. Median percentage reduction from baseline ranged from 50% to 67% for convulsive seizures and 46% to 66% for total seizures. The convulsive seizure responder rate more than or equal to 50%, more than or equal to 75% and 100% ranged 51 to 59%, 33 to 42%, and 11 to 17% of patients across visit windows respectively. Adverse events were reported in 88% of patients and serious adverse events in 41%. So 8% withdrew because of adverse events. There were 20 deaths during the study deemed unrelated to the treatment by the investigator, and 3 were due to sudden unexplained death in epilepsy. Most common adverse events are diarrhea in 33%, seizure in 24%, and somnolence in 23%. This is the data bar gram. It represents the treatment response rate, and that is more than 50 efficacy analysis set for treatment response rate, that is to more than or equal to 50% reduction, more than or equal to 75% reduction, and 100% reduction in seizure frequencies. So LOCF method is used for missing data. Discussion. Final analysis of the pooled expanded access program data confirms that add-on CBD was associated with sustained reduction in convulsive and total seizure frequency for up to 192 weeks with an acceptable safety profile. After more than 3 years in expanded access program, CBD treatment was generally well tolerated and safety profile was similar to that reported in the prior expanded access program analysis and randomized control trials. Limitations of this study: it was not placebo controlled and the investigator and patients were not blinded. The methods for reporting of seizures vary from one study site to another and not all information was uniformly collected. Because this epilepsy study consortium was not involved in the verification of seizure types, there may have been some inter-site variability in classification of seizure types, and the sample size was not evaluated at the start of study. Because of the local difference in data collection, there was a lack of details on epilepsy etiology in a substantial proportion of patients. Almost all patients in expanded access program were taking multiple medication, so there is a potential for drug-to-drug interaction which can affect this efficacy and safety outcomes. However, these interactions were not evaluated in this study. Conclusion: The results of this final analysis of the pooled CBD expanded access program data supports the long-term use of CBD treatment for patients with treatment-resistant epilepsy, and the results may provide insight into the long-term safety and efficacy that can be expected in clinical practice. Thank you, sir.
Thank you very much, Dr. Arya. Now we will go to Dr. Bhavya for the analysis of the article. Over to Dr. Bhavya. Dr. Bhavya, please.
Screen is blank. Okay.
Good morning, sir. Good morning, everyone.
Good morning. Good evening.
Sorry, good evening, sir. I am going to present journal analysis regarding the topic long-term efficacy, safety, and of cannabidiol in patient with treatment-resistant epilepsy over 4 years. Result from the expanded access program. According to the study name, it is a observational study. So I would like to checklist according to STROBE statement. So with this, all the headings, we will go by one. Title of the study: long-term efficacy and safety of the cannabidiol in patient with the treatment-resistant epilepsy. 4-year results from the expanded access program. It is not reflecting the study question, study outcome, and as population of the study is not mentioned. Study design is not mentioned. Abstract mention the background of the study, conclusion, methods, and results. Objective: specific objective including any perspective hypothesis. General objective of the study is to assess the efficacy and safety of the cannabidiol as an add-on treatment for the patient with treatment-resistant epilepsy in real-world setting. With this article, may not mention the formal hypothesis. Methodology: study design is observational study. Describe the study setting, location, relevant dates, and including recruitment, exposure, and follow-up data collection. This article is about the long-term study cannabidiol treatment-resistant epilepsy. It discussed the efficacy and safety of CBD in patient with epilepsy. So, study was conducted at 35 centers in US. Setting is 35 epilepsy center in United States. Recruitment period is January 15, 2014 to 31st January 2019. Follow-up period is up to 192 weeks. Data collection is throughout the study at regular visit. Participants: the article describes an open-label expanded access program on use of CBD for treatment-resistant epilepsy. The patients were recruited from 35 epilepsy centers across the United States. Inclusion criteria may require patient to have treatment-resistant epilepsy and to receive stable dose of anti-seizure medication for at least 4 weeks prior to enrollment. All other details regarding eligibility criteria and selection of the participants are not mentioned in the article. Variables. Outcome: the primary outcome of the study was change in the seizure frequency from the baseline. The responder were defined as a patient who had 50%, 75%, or 100% response in seizure frequency from baseline. Adverse events were also documented in the outcomes. Exposure. Exposure in the study was CBD used as add-on treatment. Predictor: the predictors, the article does not explicitly mention predictor analyzed in the study. Potential predictor could include the baseline seizure frequency, duration of epilepsy, and type of epilepsy. Confounders. The article does not discuss potential confounders. However, potential confounders in the study of the epilepsy treatment could include factors such as age, sex, and comorbid condition. Effect modifiers. The article does not discuss effect modifiers. However, potential effect modifiers in study of epilepsy treatment could be factors such as type of epilepsy and specific anti-seizure medication being taken. Diagnostic criteria. The diagnostic criteria for treatment-resistant epilepsy were not stated in the article, but treatment-resistant epilepsy is typically defined as a failure to achieve seizure control despite trying 2 or more appropriate anti-seizure medication at therapeutic doses. Data source measurement. for each variable of interest, give source of data and details of method of assessment. The document is not about the clinical trial and does not discuss the method of assessment or comparability of assessment methods. Bias. The author acknowledged potential bias arising from financial ties to manufacture of the drug being studied. Specifically, several authors received funding from Greenwich Biosciences, now the part of Jazz Pharmaceutical, the manufacturer of Epidem. Additionally, one author serves on the scientific advisory board of Greenwich Research. To mitigate this bias, the authors disclose these financial ties. Study size. Explain how the study size was arrived. The document says that the sample size was not predetermined but depended on the number of patients enrolled at the study sites. Quantitative variables. Explain how quantitative variables were handled in the analysis. If applicable, describe which grouping were chosen and why. The document discusses the study to use CBD for treatment-resistant epilepsy. The analysis include looking at the efficacy and safety outcomes. The efficacy was measured by the median percentage change from the baseline in monthly convulsive and total seizure frequency. They went to look at multiple time windows throughout the study, including 12, 24, 48, along with till 192 weeks. Responders were defined as a patient with more than equal to 50%, more than equal to 75%, and 100% reduction in seizure from baseline. Safety was measured by documenting adverse event. Statistical method. Describe all statistical method, including those used to control for confounding. The document does not discuss any statistical methods. Describe any method used to examine subgroups and interaction. Document does not discuss any examine of subgroups and interaction. Explain how missing data were addressed. The document mentioned that last observational carried forward, LOCF analysis was used to address missing data. LOCF analysis essentially uses the data from last available visit window from all the patients with the post-baseline efficacy data for analysis purposes. This approach is used to account for missing data and minimize the potential for bias caused by dropouts. Describe any sensitivity analysis. The document does not contain any description for sensitivity analysis. Descriptive data. Give characteristic of the study participant, that is demographic, clinical, or social, and information on exposure and potential co-founders. According to the article, the study participants were patients with the treatment-resistant epilepsy, taking a median of 3 anti-seizure medication at a baseline. The document does not mention demographic, social characteristic of the participant or discuss potential confounders. Indicate the number of participants with missing data for each variable of interest. It does not mention any number of participants with the missing data for each variable. Summaries follow-up time, that is average and total amount. The document says the study followed patient for up to 4 years. In that time, 64% of patients remain on the medication. Outcome data reports number of outcome events or summary measure over the time. The document says the study followed patient for up to 4 years. The findings suggest that CBD is associated with substance reduction in seizure frequency for up to 192 weeks. Overall, CBD was well tolerated. In detail, the document reports the following. The median percentage changes from the baseline in monthly convulsive seizure frequency was 88.9% at 192 weeks. The median percentage change from baseline in monthly total seizure frequency was 70.7% at 192 weeks. Responders were defined as a patient with more than or equal to 50%, more than or equal to 75%, and 100% reduction in seizure from baseline. The percentage of patients achieving these responses increased over time. For example, at 192 weeks, 62.5% of patients had a more than 50% of reduction in monthly convulsive frequency. 42.3% had more than or equal to 75% reduction, and 23.3% had a 100% reduction. Main result: give unadjusted estimated and, if applicable, co-founder adjusted estimate and their precision, that is 95% confidence interval. Make clear which co-founder were adjusted for and why they were included. The document does not contain any estimated or co-founders. Report the category boundaries when continuous variables were categorized. The document does not mention how continuous variables were categorized. If relevant, consider translating estimate of relative risk into absolute risk for meaningful time period. This document did not provide any data on absolute risk of epilepsy in general population. Therefore, it does not possible to calculate the absolute risk of epilepsy for patient participant in the study. Other analysis, report other analysis done, that is analysis of subgroups or interaction and sensitivity analysis. The document does not contain information on other analysis done, such as analysis of subgroups, interaction and sensitivity analysis. Discussion. Key results. Summarize the key result with reference to study objectives. This is an article about a long-term study of CBD for treatment-resistant epilepsy. It discussed the efficacy and safety of CBD in patients with the epilepsy who did not respond to other medication. The study found that CBD was associated with sustained reduction in the seizure frequency for up to 4 years. Most patients tolerated CBD well. In the study, 64% of patients remained on treatment after 4 years. The result was the study support its objectives of evaluating efficacy and safety of CBD as an add-on treatment for patients with treatment-resistant epilepsy. A limitation of the study. The authors acknowledge a few limitations of the study. First, the study was open label, meaning that all participants knew they were receiving CBD. This can introduce bias because both patient and researchers may be more likely to report positive effects and less likely to report negative effects. Second, the study was not controlled, meaning there was no comparison group of patients who did not receive CBD. This makes it difficult to determine whether the observed improvements were due to CBD or to other factors, such as placebo effect or changes in the medication. Third, the study was founded by the company that develops and sells CBD products. This creates a potential financial bias, as a company may more likely to fund research that shows positive results for CBD. The magnitude of this biases is difficult to determine. However, it is possible that this positive effect of CBD may be overstated due to these biases. Interpretation. Give a cautious overall interpretation of result considering objective, limitation, multiplicity of analysis result from a similar study and other relevant evidence. The study investigates long-term efficacy and safety of CBD and as an add-on treatment for treatment-resistant epilepsy. Patient receiving CBD for up to 192 weeks. The study found that CBD was associated with sustained reduction in seizure frequency for up to 192 weeks. Overall, CBD was well tolerated. However, some limitation to study design should be considered. First, this was an open label study, so there was no placebo control group. Second, this means that observed improvements could be due to placebo effect. Second, the study relied on data that was collected during the routine clinic visits, which may not be accurate as data collected in more controlled setting. Third, the study did not assess the long-term effects on CBD on other health outcomes. Overall, the result of this study are promising, but more research needed to confirm the efficacy and safety of CBD for long-term treatment of treatment-resistant epilepsy. In interpreting this result, it is important to consider the limitation of the study. The open label design could have led to overestimation of the treatment effect. Additionally, the study did not collect the data on all potential side effects of CBD. Despite this limitation, the study provides some evidence that CBD may be an effective and safe treatment for treatment-resistant epilepsy. However, more research is needed to confirm these findings. Future studies should be double-blinded and placebo controlled, and they should collect the data on long-term side effects. Generalizability. Discuss the generalizability, external validity of the study result. The generalizability of the study result may limited due to the following reason. The study was open label, meaning all the participants knew they were receiving CBD. This can make it difficult to determine whether the observed improvement were due to CBD or to the placebo effect. The study was conducted at the 35 epilepsy center at the US. The result may not be generalizable to the patient, to the other countries and healthcare settings. The study include patients with a specific type of epilepsy treatment-resistant epilepsy. The result may not be generalizable to the patient with the other types of epilepsy. These are just some of the limitations that maybe affect the generalizability of the study result. More research is needed to determine how well CBD works for the wider range of patients with epilepsy. Funding. Give the source of funding and the role of the funders for the present study, and if applicable for the original study on which present article is based. The source of the funding for the study was grants from the Greenwich Research and Epilepsy Therapy Project to the Epilepsy Foundation. Greenwich Research provides CBD free of charge administrative support across all sites, and some sites with funds to support the study. At some sites, funds were provided for salary support of for the staff time spent on activities required for the extended access program. Greenwich Research also collected data from the sites and conducted the statistical analysis. It is important to note that the funding source may create a potential bias, as a company that manufactures the drug being studied may be more likely to fund research that shows positive results for the drug. Thank you.
Hello. Yeah, thank you, Dr. Bhavya for that excellent dissection and presentation. Also, Dr. Arya sir. Now, we would like to hear from Dr. Ramankutty sir, or to Dr. Ramankutty sir for the expert analysis.
So you're muted, sir.
Okay, am I audible now?
Yes, sir.
Okay, first of all, let me say it's a very interesting study, both because of the nature of the intervention, which is very unusual. Maybe it is something very novel. So it was very interesting. And secondly, because they have kind of adopted a very unconventional approach to this study. First of all, let me say both the presenters did an excellent job. A very good presentation. And I am really happy about the person who analyzed the study, because it's easily mistaken as a trial, because they have stated that it is an open label, etc., etc. But actually it's nothing like, it's more like a cohort. It's an observational study, and she correctly identified it as an observational study and went by the STROBE guidelines, which is the correct thing to do. And of course, she pointed out most of the drawbacks in the study, mostly that they have got a lot of rich data, but instead of doing a good statistical analysis, they just described some margins and left it at that. So that was, I think, the major deficiency in the study. And if you look at it, the completion rate is only around 64% something, which is not very good. So in any cohort of this nature, you wouldn't really completely depend on the results with the completion. The dropout rate is so high. So we have to look at it again. So that is one major issue. So all these were actually pointed out by the discussant. And also the question is, why they didn't do a controlled trial, because after all this, they are saying, we have to do more studies, and probably that study is probably going to be a randomized trial. Even if it's an open label trial, you can still gain some insights into whether it is better than any other combination or routine treatment which we can offer. So that is again, so we are again back to square one. So that is the problem of the study, is that it doesn't really answer many questions. And also, as it has been pointed out, I think a lot of the people involved are really promoting this drug. So that is, of course, they have pointed it out as a conflict of interest, but we should also look at it in that way, that they want to say that this is good and more people should use. So we should be very cautious about accepting it. And I will stop with one more observation, because this kind of intervention is now coming up. I'm sure many of you must be aware that these very unconventional therapeutic interventions are coming into many areas in medicine. And recently, there have been a lot of studies on what is known as magic mushrooms and their effect on psychosis. And they say that actually it's one big jump in psychiatry. That is one of the, in psychiatry, there has been no major new drugs for a long period. And now they say that this may be the next thing. And people who have gone through that treatment say that they feel as if their whole brain has been rebooted, like rebooting your computer. You are at the next level. So I don't know, but again, we have to be a little careful in assessing this kind of approaches. But maybe there is something in it. We can't rule it out also. So maybe this is also a promising intervention. That's all I would like to say. Again, once again, I congratulate the discussants and also the whoever suggested this article. I mean, I think it's very interesting. We should be aware of these developments, right?
Thank you so much, sir. Or to Dr. RoseMary Lawrence, who is a mentor. Madam is a pediatric neurologist also. Or to Dr. Rose, she's the mentor of these pages also.
Yes, sir. So why I chose this article was precisely that reason. What I wanted to know is how do we assess a new drug when it comes into the market? So that the PGs also need to learn, because there might be new drugs coming up, and these pharma companies, they push a lot of drugs, sometimes unnecessarily. So it is always needed to, see how powerful the study is. Is it good enough for us to, believe what they're saying? So I thought this would be a good introduction to that. So that's why I chose this study. I think the study actually was putting us more in a fix whether it is reliable enough to use. But when you look into multiple studies, this cannabidiols have some amount. They have this efficacy that has been described in this study, and it is showing some promise in treatment resistant epilepsy, like how Padmanabhan sir said that even if the seizures frequency comes down from 15 to 2, it makes a huge difference for the parents. So yeah, the drug shows promise, but the only problem is that the cost is very limiting. Only recently it has been launched, maybe 4-5 months back it has been launched. We have a 60 ml bottle costing around 8,499 range. That was one of the medicines. There are 2-3, all Intas, Sun Pharma, Cipla, all have launched theirs. It's somewhat in the same range. So if for a 10 kilo baby, if you start the drug, the medicine will last for only 2 months. So that's going to be a huge financial burden. So we have to be very careful when we start using such drugs. But all said and done, still, since there is promise, with selective cases we can use. Currently, it has been approved for Dravet, Lennox-Gastaut, and tuberous sclerosis complex related resistant epilepsies. But the study was very deficient in all that. They have not chosen a specific indication. They have broadly taken treatment resistant epilepsies. So the net effect, even if they actually wanted to demonstrate the power of the drug, they could have done a better study, and I think that could have given us more confidence in using the drug. So that is what I thought that PGs can learn in this session.
Thank you, Dr. Rose. We have Dr. Rajmohan sir with us. Respected Rajmohan sir, could you please be kind enough to share your thoughts regarding the study, sir? Dr. Rajmohan sir.
Thank you, Anju. Actually, I didn't read the paper. I just wanted to, what is happening in your journal club, I just wanted to peep in and see. Because only 1 or 2 comments, RoseMary or somebody said as bias. It is not bias, it is only conflict of interest. Conflict of interest is different from bias. So bias is just a deviation from the study results. It is a validity concern. Conflict of interest is something different. So
okay.
Remember from your presentation. Otherwise, Ramankutty sir said it is actually very easily misunderstood, because these are all company creations. Of course, there is no other way to study the effect of interventions in refractory epilepsy like this. These are all, otherwise not treated. It's very difficult, real problem cases. So things are justified. I don't know. I have not read the article, but I am very much interested to see the ethical considerations what they have described, because how if there is, I don't know what is the standard care for such cases, because standard care is very important. in your protocol? There may be some standard care.
Yes, sir. Each disorder has a standard protocol. But that's what they have not been specific on which protocol for which they have not specified which disorders, epilepsy disorders or epilepsy syndromes they have been treating. So that clarity is not there. So then it is difficult to say whether what is the standard of care. So it's too broad to get a good clear picture about the drug use.
Whatever they say, even in terms of intervention effectiveness, an observational design is not at all indicated, and it is not a powerful design. It is not a valid design. That is a major flaw in this study. Anyway, thank you very much because I'm not making any serious comments. I have not prepared for any serious comments. I have not read the article. Sorry, I just wanted to know because I thought of associating with more and more with the pediatrics. So because I have to come back to pediatrics at one day soon.
Thank you, sir.
I just
Thank you,
wanted to
sir.
keep. Thank you very much.
Madam.
Yes,
Dr. Kalpana madam is also
Kalpana
available.
madam has joined,
Madam is a eminent neurologist and teacher.
Hello.
Or Dr. Kalpana madam.
Actually, this is a study. The cannabidiol has been actually accepted for the conditions that Dr. RoseMary has told, like the STROBE, tuberous sclerosis, etc.
Madam, you're breaking, madam.
Connectivity issue, I think.
But
Madam,
other types of treatment resistant. So this is the
The connection is for the
treatment that is resistant. Means they are used. 3 drugs are used in the correct dose. The chance for is even then, if it is resistant, the chance for it to become responsive to other drug is very low, like 5 or 10%. So compared to that, this is found to be a little higher. That is the thing. And they want to promote the drug. That is the main idea. But the thing is, in treatment-resistant epilepsies, only surgery can cause some 10% improvement. Ketogenic diet is said to have some 15 to 20% improvement, and all others less than 5% if 3 drugs are not found to be effective. So all these are very resistant epilepsies with a multiple number of events in a day, like that. So a reduction of more than 50%. So treatment-resistant epilepsy is actually not a single group. It is a heterogeneous group. So many types. It can be genetic,
Okay.
it can be structural, it can be metabolic, so many things.
Madam, what is your opinion regarding the trials with the cannabinoids, madam? What is the status like right now?
Actually, in this study also, some 17% of some patients have got complete control of seizures. That is something that is commendable, isn't it? So with so many episodes of seizures, in spite of 3 anti-seizure drugs, even 10% patients becoming free of seizures is because of the drug effect. It is found to be effective.
In India, are there other centers also in India, madam, which is using? Have started using the drug, madam?
Actually, the drug is available for many years. Drug is available in India, manufactured in India for the last 4-5 months. That's all. Drug is available outside India for many years now. That is why this study is done in 2014 to 19 or something like that.
Yeah. Thank you, madam. That was what Rose was also telling. Now, over to Dr. Padmanabhan, sir. Sir, your opinion and.
Yeah, so I had the same opinion of many people already said. 1 or 2 things which I would like to say here is that they have come to the conclusion that it is well tolerated. And then they are saying that 36% of the people withdrew, and the major reason was the side effect. And lack of efficacy was. How can you say that? When you say that 36% withdrew, and the major problem was side effect like diarrhea, vomiting, and something else. and then you say at the end of the day it was well tolerated. I don't understand that. And they also say that the acute, side effect, 41% was serious. I don't know what was serious about it, but if it was 41% serious, 36% withdrawal because of majority of them due to side effect, you can't say that the drug did not have. And I have no idea about this cannabis. I have only read it in some books. I would like to ask Dr. Kalpana and Dr. Rose, is it in any guideline? Any guideline anywhere?
No.
What do they say about it?
Actually, I have not started using it. Diarrhea is said to be one of the side effects that patients cannot tolerate. And drowsiness also is said as an important side effect. Other than that, very serious side effects are not there, but these are difficult to tolerate for the carers as well as the patients.
No, my question was, if it is there for 4 or 5 years, has any guideline, American guideline, European guideline, ever talked about this, or have they included it in the list of resistant epilepsy?
Yes, sir. Some consensus guidelines are there where they have asked as add-on.
As an add-on, they said.
Yeah, for these three, especially these three conditions: Dravet, tuberous sclerosis complex, and Lennox-Gastaut.
And do we? I have not found any pediatric. Any patient on these medicines. Though I see many resistant epilepsy treated by pediatric neurologists. Have they started using it in India?
Yes, sir. They started. Sri Chitra started. Madam, medical college.
Actually, I have also started for just one patient only. Just started only. I cannot say whether it is useful or not. But definitely, pediatricians wanted this drug to come to India. Pediatric neurologists wanted it to come to India because otherwise the cost was 4 times high. Now, at least some people can afford.
Yes.
So we have to see. And before writing, actually, we have to see whether the patient can use it at least for 3 months. Then only we will be able to say whether the drug is effective or not. If one bottle in a 20 kg child, it won't be sufficient for even a month.
Yeah.
So they cannot, if they cannot afford that, because already they are on 3 or 4 drugs and they may be spending quite a lot of money. So the patient has to be able to do that.
Yeah, but there are many parents who would say, give me any drug. I'm willing to spend a lot of money, but I want the seizures to reduce. For them, we can try. Isn't so, madam?
We can definitely try. But the problem is that everyone wants an immediate result. And this drug has to be started in a small dose. And every 2 weeks, the dose has to be increased. So the parent has to be informed that at least 2 to 3 months, they have to wait. If just by starting on the day 1, they may say that the seizures are not they have not reduced, and immediately they may stop with a single bottle. That is the problem. You have to tell them and you have to make them understand. Otherwise, everyone will be starting and then they may be stopping. Here also, maybe because of the decrease in effect, maybe many people have stopped because they were not believing. And the medicine was completely free also.
Yes.
Will it be a controlled prescription like opioid? Well, this is
No.
Yeah. Normal.
This drug has no addictive effect. That is what they're telling. No addictive effect.
Madam,
that
is what one question I have actually. Madam, we have this tetrahydrocannabinol and cannabidiol. So what we are having in this medicine is cannabidiol only. So will there any psychotropic effects as far when children consume this medical cannabis?
No.
According to literature, no. And there is no addictive effect. That is what is mentioned.
Okay. Ramankutty sir, one doubt we were having is regarding the conflict of interest, because many persons have raised the question of conflict of interest. In this study also, sir, what does this conflict of interest exactly mean? And if in any study, if some pharma company actually contributes some money for the study and all, how will we make sure that the study is not, biased or skewed or having any issues and could you please throw some light on that?
No, just because some pharma is funding the study doesn't mean that there is a conflict of interest. Conflict of interest comes when you are receiving, the investigator is receiving some benefit from, and of course, as you know, some of these things people don't reveal, but actually, suppose you are a shareholder or, you are a part of the company, you're also an investigator, clearly there is a conflict of interest. So that is what you have to declare. But all these things that pharma companies do, like sponsoring conferences abroad, actually also that is also a conflict of interest, but nobody wants to talk about it. So that is another story. I don't want to elaborate on that. So if you want to be a very fair investigator, you should not be accepting anything from them. Only accept the funding for the study. So I don't know whether any such ideal Maryada Purushottamans exist. I'm sorry to say.
Sir, one more.
But a control trial, placebo control trial can be done, isn't it? A placebo control trial can be done.
Yeah, that's right. I mean, design can be better than this.
Sir, one more thing is regarding this last observation carried forward, sir, LOCF. Sir, could you throw some light on this LOCF?
Actually, I also didn't understand what is that last observation.
See, the thing is that, in large studies, there will be many missing observations. So when in statistical analysis, the missing observations are a big problem. So what usually happens is the whole data on that person will be dropped because there is one missing observation in most of the software. So what they do is what we call imputation. That is that missing values are supplied. Either they take the mean of the other observations and put it as that's called the mean imputation. Sometimes there is a median imputation. And here what they have done is, because it's a serial study, whatever happened at the last time, if the next time the observation is missing, they carry that value forward just to fill in the data. And then again, that depends on how many missing observations were there. That is not very clear from this, at least what I could understand. There are a lot of missing observations and just they're carrying the last observation forward, then it becomes meaningless.
Actually, is it not a source of bias, See, the people who don't come for follow-up are people who are not happy with the treatment usually. And exactly. In fact, I was observing, you remember that preterm follow-up, they used to say that when we were, I was a tutor in pediatrics, preterm babies, they followed, they had normal development in 80%, 90% like that. But the dropout was 10%, 20%. It was one Indian doctor, pediatrician, UK warrior in US, in Britain. He followed up he used to drive 400 kilometers to see the patient who has not come for follow-up. And he showed all the patients who dropped out had a very bad prognosis, have a very bad development. And therefore, that's why they didn't come for follow-up. Therefore, that was a path-breaking study. Therefore, he said it was not as, as good as what it is written in the books. Therefore, here also, when you say that there is 36% withdrawal, mostly they didn't have the good effectiveness. They didn't have the good response. The people who respond will keep on coming. That's a bias. Am I right?
Yeah, quite right. Because that is one major problem in the study is that you have a large dropout rate, and this kind of dropout rate, then you can't believe what is. Because whatever percentage is left will have a high positivity because they are the people who have had good results. Yeah.
Sir, regarding the quality of life, they were mentioning about the quality of life. Sir, ideally, when you assess the quality of life in a study and all, should not be there some tool for assessing the quality of life, sir?
There are a lot of tools for assessing quality of life, including WHO tools. Then you have the 5 questionnaire, 20 questionnaire, depending on what you want to do. Also for specific illnesses, they have developed quality of life assessment tools. I don't know which one they use.
You see, one thing we shouldn't miss is that in patients with resistant epilepsy, the quality of life is mainly dependent on the epilepsy only. What quality of life they can have if they get 5 or 10 seizures, and many of time they fall down, they break, the whole family is affected. Therefore, any even marginal effect is a substantial effect for the family. That's what I found. That we shouldn't forget. I think definitely this has a role. If they can afford, it's great.
Sir, Dr. Rose, in the study also SUDEP is mentioned and all. So what are the common causes of SUDEP? So in spite of the control of the seizure, increasing quality of life and all, still death can happen. So what would be the risk factors for SUDEP, and what are the common causes? Could you please tell a few words about that?
Still, the major risk factors are if you don't take the medications regularly, or if the type of seizure is generalized seizures. Then other risk factors like drinking, etc. I mean, those things can add on to it. Sleeping prone, those things are added risk factors. As of now, the definite etiology for SUDEP is not known. It is described as a cause of death, which is not due to status or any known cause. So that is what SUDEP is described as. So usually, some of the studies show that like there are some cases where the EEGs have picked up some EEG abnormalities. So in those, what they have noticed is that it leads to mostly it leads to a respiratory failure followed by asystole. So it can be a electroencephalographic cerebral disturbance, which affects the respiratory, cardiac, or electrocerebral function. So that will lead to death. So usually the patients are noticed in prone position, and they are usually unmonitored. It usually occurs at night. So on the whole, what can be done to prevent it is take your medicines regularly, and monitoring facilities. People are looking into monitoring facilities which can, give alarms. All that is being considered. So still, some of the deaths cannot be explained. Kalpana ma'am, do you want to add anything?
This SUDEP, one is actually in children or adult with uncontrolled epilepsy. It is more common, and certain types of epilepsy like Dravet syndrome or certain types which are occurring at night. Night is definitely there, and in Western countries, children often sleep alone. Here, most of the children will be sleeping with their parents, even if they're adolescents, especially. So here, I think the number may be comparatively less compared to the but even now here also there are patients, suddenly there is death, and often at night, and we don't know whether they have a seizure or not, but most of them have uncontrolled epilepsy, and some specific types have got increased chance for SUDEP. So we have to actually tell the parents regarding SUDEP when we diagnose epilepsy, which is if it is not responding to 1 or 2 drugs.
Thank you, madam. Now, the topic is open for discussion. So if anybody want to clarify or to contribute, they can right now. I would like to request Dr.
Anju, I think that the most remarkable thing, personally, I feel today's evening was the performance of Rose's postgraduates.
Thank you, sir.
Especially in the second part, particularly the interpretation part of this, the analysis. Yes. I think that was very good. I think we got an insight into the article, and we even before the master, like Ramankutty, discussed the positives and negatives of the study. We could understand. Being a pediatric cardiologist, I could understand the some final nuances. I think that is very good. Second, I agree with Padmanabhan. 40% adverse effects and some 36% going away. And then you are saying that's a very great drug. That is another point I want to ask Rose is that there are 35 US centers. So naturally, some of the US centers must have had surgical centers also, surgical programs for
Yes, but they have
epilepsy.
not
So,
specified which. Yes, sir. Your question?
where they tried surgery was tried, or was it not an option?
They have
They have
not.
not mentioned.
They have not clarified on that, sir.
Okay, surgical option was not
No,
uh,
it's not mentioned.
mentioned. Okay. So
Thank you
what
so
will
much,
be
sir.
the what will
Sir.
be the suppose you have 3 to 10 drugs, some children were getting 3 to 10 drugs at some time. Maybe. So what would be the what you call standard thing, what does it go, what about that the message or the pediatrician looking after a patient who is
in treatment
having
refractory
multiple
epilepsies, it is very difficult, sir. We often hit a wall, so multiple drugs are sometimes the modality of treatment that is chosen.
So, is it okay to be tempted by cannabinoid?
Yes, sir. Yes, sir. We should definitely. Yes, we should definitely try wherever it can be afforded. It is a drug of promise only. We should at least and we can get our own data. So that
only thing is, as Kalpana was saying, diarrhea is a major issue. Then 40%. So if you remove that portion, I think some of them may do well, because it's a very important point. 10% had a 0 seizure. That is great, no?
Yes.
That is also.
One thing, Sulfi, is that they have said that the seizure associated with Lennox-Gastaut syndrome, Dravet syndrome, and tuberous sclerosis. These were the usual things which was taken out.
They were
now
basically
the patients
not.
Who require surgery are a limited.
Yeah, correct. They were not surgical candidates.
They must have been excluded, sir. But they have not given it in the exclusive
anyway, these 3 conditions are more likely to be surgically not, indicated situations. I think. Correct.
Thank you, sir.
Thank you.
Sir, Hariprasad, sir, want to add something, sir? Hariprasad, sir? I think.
Hello.
Sir.
Thank you, Anju.
Yes, sir.
Sulfi sir, I think both the presenter and the discussant performed extremely well, and the topic was also of really interest. So congrats to Rose and your PGs.
Thank you, sir.
I think I go for palliative care conference also, and I think this cannabidiol is in the market for probably many years, especially in treating intractable pain. So I think so cannabidiol is going to come in a big way in our market also. So probably for pain as well as for seizures and probably for other conditions also in the near future. I think we have to embrace this cannabinoids in that aspect. Most of the around 70 to 80% of children getting registered in palliative care are suffering from chronic neurological conditions, and almost all of them are having intractable seizures, and the quality of life is extremely poor. And actually, one of our PG in SAT did a study on the quality of life and as well as for the expenses, and it was showed that around 80 to 90% of the family income was spent on the index diet. That is, who is having an intractable seizure or any other problem. So I think even if it's a little bit costly, and also it was showed that about 70 to 80% of time they come by private transportation. That means they had to spend minimum 10 to 15,000 rupees per month on this child. So if you propagate this cannabinoids in a big way, actually, if you calculate the expenses and the benefit, definitely I think that will bring down the burden on the family, including the financial aspect. And I think IAP Trivandrum is a very vibrant branch. We have got a lot of medical college as well as very lot of other private hospitals as well as a lot of pediatrics and pediatric neurology. So I think IAP Trivandrum branch should come up with multi, just like this study, 35 centers. I think we can select almost all the hospitals in Trivandrum, and we can do it and then case control and we can come out with a very good final message also. So that is my advice. That is okay. Thank you, Anju, for that.
Thank you so much, sir. I think we have come to the end of the session and all. And one comment was there in the by Dr. Shilja, but that question was answered regarding the side effects and all. And yesterday was the World Epilepsy Day. So today we were discussing with RoseMary regarding the selection of the article, and I also insisted on this, and it has come out to be useful as well. And I would like to request Dr. Benno to conclude this session. Over to Dr. Benno. Thank you all for the joining us, and thank you for the PGs. Thanks for the PGs. Thanks for teachers, Dr. Ramankutty sir, Padmanabhan sir, Zulphikar sir, Hariprasad sir, Rajmohan sir, and Dr. RoseMary. Or to Dr. Benno.
Thank you, Anju sir. It wouldn't be right to say that my PGs or Cosmopolitan PGs have done extremely well. I'm very happy to hear comment from our dear Zulphikar sir that they have presented it so wonderfully. First and foremost, congrats to both Arya and Bhavya for presenting it so, for that lucid presentation and doing the presentation very well. Congrats once again. And of course, our IAP treasurer, Dr. RoseMary Lawrence, who's a mentor for the students, and she has done a job very well. And under her guidance, the PGs have done very well. Thank you, Dr. RoseMary. And I would like to thank Ramankutty sir and the expert analysis, and Padmanabhan sir, the Journal Club coordinator, for as I said earlier, that they have been conducting it very meticulously and are going forward in a big way and is carrying the Journal Club presentation very well. And of course, our Anju sir, the Journal Club joint coordinator, for coordinating the sessions, all our journal clubs very well. Thank you once again, sir. And I would like to thank the audience who have contributed so well. Zulphikar sir, then our IAP TVM President Hariprasad sir, and all others who have
Rajmohan sir,
Rajmohan sir, yeah, and Rajmohan sir also.
Kalpana madam.
Thank you. Kalpana, of course, our dear Kalpana madam. Rajmohan sir and Kalpana madam, thank you sir and ma'am. And yeah, last but definitely not the least, yeah, all the audience for the patient listening. Thank you all once again.
Thank you.
Good night. Good night, all.
Thank you so much. Take care.
Thank you, sir.
Yeah, right.